Thank you so much.
Can everyone see that okay? Awesome.
Perfect. So PCOS is one of my interests. I treat a lot of young females and females throughout their whole lifespan with PCOS, and it's something near and dear to my heart. Actually, women's health in general is near and dear to my heart. So I hope that I can impart just some guidelines and knowledge today from my own reading and expertise over the years. So we'll get started.
Dr. G, you're still muted.
Can you hear me now?
Now we can, yes.
Sorry, I lost the screen with the slides for a second there, and I must have muted myself in the meantime. So our objectives will be to describe PCOS and the pathophysiology, to identify risk factors and conditions that are related to PCOS, and then go through treatment options. Next slide, please. The disorder that eventually would be known as PCOS was initially described by these two gentlemen, Stein and Leventhal, back in the 1930s. So it's been around for quite some time. Next slide, please. As far as epidemiology goes, this affects about 6 to 10% of women of childbearing age, and that's equal to about 3 to 5 million women. It's the most common cause of female infertility, about 50 to 60%, and it may be the most common endocrinopathy in young women. Next slide, please. The potentially affected patient populations that should raise an alarm when you see them in clinic, it's several populations of females who are at risk for this. And they include reproductive age women with clinical evidence of hyperandrogenism. That means hirsutism, or thick unwanted hair growth, acne, alopecia, which is hair loss, with menstrual or ovulatory dysfunction, with a history of polycystic ovaries, and that would have been detected per a pelvic ultrasound, most commonly done by their OB team, or with insulin resistance, metabolic abnormalities, or obesity. So as you can see, there's quite a few females that should be screened, for PCOS. Next slide, please. It has a huge economic cost to healthcare, about $4.36 billion. So just incredible cost. And a lot of that is just the screening, the lab testing, lab retesting to make sure that PCOS is confirmed. And I'll go through that in a little bit, but I feel that a lot of women have symptoms for years and it's really unexplained. And then unfortunately, what happens is with PCOS, there's multiple different governing bodies that have their own diagnosis of PCOS, which further complicates a diagnosis and treatment for these women. So it's frustrating because I do wish that all governing bodies would come together and have one diagnosis, honestly, for ease, to help clinicians and providers to be able to give women a diagnosis. And I'll go through that in a little bit more depth when we go toward diagnosis. Next slide, please. The diagnosis of PCOS implies that a woman is at increased risk for the following: infertility, dysfunctional uterine bleeding, endometrial cancer, obesity, obstructive sleep apnea, type 2 diabetes, hyperlipidemia, hypertension, cardiovascular disease, and then any of sisters, daughters, or other close female relatives in the family will also be at risk. And she may require lifelong therapy to treat all of the above. Next slide, please. The pathogenesis of this disease, it remains unclear. It's a complex genetic disorder that has multiple hypotheses of why it comes to be. The thought is that there are ovarian genetic traits involved, that there's a dysregulation of steroidogenesis and insulin resistance. And so there's multiple different ideas behind what causes it. And I'll try to go through some of the hypotheses. Next slide, please. So the pathophysiology of hyperandrogenemia in PCOS is thought to be illustrated in this drawing here. And I apologize, I know this slide is really busy, but I wanted you to have this as a reference to be able to go back to. And I think sometimes a picture speaks a lot louder than words. So this is basically on the left side, your hypothalamic pituitary axis and how it talks to the ovary. So the HPA axis is up there in the kind of light purple on the left, and then the ovary or granulosa cell in particular is down there in the purple to the bottom left. So since ovarian steroidogenesis requires gonadotropin stimulation from the pituitary, LH is a key factor in the hyperandrogenemia of PCOS. And LH is luteinizing hormone that is released from the pituitary gland. Progesterone is a primary regulator of our GnRH pulse frequency, which that's a fancy way of saying the pulses that come out of your master pituitary gland. So progesterone in our body is supposed to be feeding back to that master pulse generator to tell it to turn off. It's kind of like if you think about comparing this to the analogy of like a thermostat and a heater. You know, when the heat in your house goes low, your thermostat in turn kind of kicks in. And so think about progesterone and your GnRH pulse or your pituitary as the heat in the thermostat. So your progesterone is the heat and the thermostat is your pituitary. And in the case of PCOS, the thermostat isn't really responding at all to the heat. Okay. So there's a problem with the progesterone being able to speak to your pituitary. So it's thought that there's a resistance to this negative feedback effect of progesterone. The resistance to progesterone feedback is thought to be mediated by too much androgens floating around in the system and results in a high pulse frequency. So that means that the pituitary is just doing its own thing. It's not listening to feedback. So the pituitary is putting out its own high frequency pulses of LH production or luteinizing hormone. And LH is what drives androgen production and limits follicle stimulating hormone or estrogen production. So therein lies the real pathophysiology behind this disease. Next slide, please. I wanted to talk a little bit about menses, just to kind of define it and so that you know when patients come in how to define irregular menses, and so that kind of triggers you to think about PCOS. Irregular menses are defined as being less than 21 days or greater than 35 days. Women with PCOS typically have a prolonged cycle, so typically greater than 35 days. Both decreased menstrual cycle regularity and dysfunctional uterine bleeding are clinical consequences of chronic anovulation. And I'm going to go through that in a minute here. Next slide, please. So if we talk about menses and ovulation, I know this is another busy slide and I'm sorry, but I thought the pictures were really worthwhile. So if you look to the left, we have a normal menstrual cycle versus what a PCOS cycle would look like. So you can really define that right in the middle of the cycle, the regular menstrual cycle, are you all able to see that spike in the level of luteinizing hormone? Now I want you to look at the PCOS cycle, and we don't see that spike at all of luteinizing hormone. In PCOS, there's high levels of luteinizing hormone all throughout the cycle. That means that there is no spike of it. And so no ovulation is triggered, We need that spike of luteinizing hormone to trigger ovulation. So ovulation does not occur. The next problem is that progesterone levels go up after ovulation. And this is because progesterone is produced by the leftover egg follicle after the egg is released. And that sharp fall of progesterone causes a bleed. And that also does not occur with PCOS. If a woman is not ovulating, there's no corpus luteum to produce progesterone. And if there's no progesterone, there's a lack of a regular period. Next slide, please. To diagnose PCOS, I use the Rotterdam Criteria. I'm going to introduce you to some different criteria, but the Rotterdam is, I think, what the majority of endocrinologists who had mentored me and what a lot of practicing endocrinologists use. So we need 2 out of 3 of the Rotterdam criteria, which include androgen excess, and that's like acne and hirsutism, the unwanted hair, ovulatory dysfunction, and then polycystic ovaries on ultrasound. It's important to know this is a diagnosis of exclusion, so we must rule out other things, and I'm going to talk about that as well. Next slide, please. So this is only to give you the other governing bodies and what their diagnostic criteria for PCOS is. I put the Rotterdam criteria in the red box. The other criteria would be the NIH, the androgen excess, and the PCOS society guidelines over there on the far right. And that's for your own use. But again, I use the Rotterdam criteria. Next slide, please. Disorders that mimic the clinical features of PCOS must be excluded, right? So we have lots of reasons to have irregular periods and symptoms that a lot of women that PCOS present with. And so things to rule out are things such as thyroid disease, hyperprolactinemia, non-classic congenital adrenal hyperplasia. That's a rare condition, but nonetheless should be screened for. In certain women that have a lack of period with more severe symptoms, more extensive evaluation needs to be done. So, for Cushing's disease, if your patient presents with severe significant weight gain, swelling, fractures, easy bruising, easy bleeding, then you'd want to screen for Cushing's. Or acromegaly would be, pronounced jaw, enlarging hands, feet, head size, sweats, foul odor. Pregnancy should always be ruled out. Functional or hypothalamic amenorrhea. So keep in mind women with, anorexia, bulimia, or athletes that can also trigger irregular periods with excessive exercise and low calorie intake. And then primary ovarian failure should also be ruled out. And typically we can rule that out with checking the pituitary sex hormones. And then androgen secreting tumors. And androgen secreting tumors are pretty, that's a malice player. So they typically present with really rapid onset, like deepening voice, hirsutism, balding, and it's rather quick onset. Next slide, please. This is simply a slide that just summarizes what I told you on the slide previously. I wanted to give you a little bit more information in case you wanted to follow up in your clinics and order specific testing. So for instance, acromegaly, you order an IGF-1. I don't feel the need to kind of go through this step by step, but it's really there for your reference in case you have, patients that you're trying to rule out PCOS, and you can use this as a reference to see the particular labs that would be useful to order. Next slide, please. The laboratory evaluation for PCOS. So these women we talked about have hyperandrogenemia, so high circulating testosterone and androgens in their system. About 60 to 80% of patients have increased circulating androgens, and this is primarily free testosterone. It cannot be the sole diagnostic criterion because about 20 to 40% of women have normal androgen levels, and assays for testosterone in females are notoriously inaccurate. The best test is a serum-free testosterone, and this can be disproportionately higher than the total concentration in PCOS. And when I say total concentration, I mean free testosterone as compared to total testosterone. I typically order both at my clinic. Next slide, please. So although not essential to the diagnosis, insulin resistance is common and may affect the treatment decisions. A fasting blood glucose, a 2-hour oral glucose tolerance test, or an A1C can be measured for hyperinsulinemia. I often see insulin levels ordered, and honestly, I typically never order insulin levels. They really don't have any end game other than in the hospital setting if I'm trying to rule out something like an insulinoma. So I don't typically order insulin levels, but I see that in women with PCOS, it's often ordered, and there's really no need for that. And then a fasting lipid panel also should be ordered. Next slide, please. So PCOS and associated conditions, I mentioned hirsutism, and this represents the PCOS is the major cause of hirsutism. Overall studies report it's in about 65 to 75% of patients with PCOS. Next slide, please. And we diagnose hirsutism by something called the Ferryman Galway score. Greater than 8, as you can see off to the right, are different areas within the body, and they're graded on a scale of 1 to 4. So a scale greater than 8 in a Black or white patient is elevated, and a score greater than 9 in Mediterranean, Hispanic, or Middle Eastern women is elevated, greater than 6 in South American women, and greater than about 2 to 7 in Asian or Chinese women. And you can see those areas to kind of look for and identify in your patients. Next slide, please. So a mild score is 8 to 15, moderate is 16 to 25, and severe is greater than 25. I think the scoring system is pretty limited because it doesn't consider the androgen sensitive areas such as the sideburns and the buttocks as well. And then scoring needs to be done by trained observation. And honestly, most women are so incredibly effective at removing their hair with bleaching and Nair and, laser therapy that I don't find the Ferryman Galway score to always be so helpful because they're so effective at kind of removing the hair before we see them. So the way that I approach it is I typically ask the question, how often do you shave, or what areas of your body are most bothersome, and kind of approach it from that angle as opposed to having them, put on a gown and look head to toe like this. But certainly this is the standardized way to document hirsutism. Next slide, please. So the role of androgens in the development of terminal hair. Hirsutism, which is thick, dark, black, kind of unwanted thick hair, is a result of the circulating androgens and the sensitivity of the hair follicle to the androgen itself. It's a misconception that it always has to be that a woman has high testosterone to cause unwanted hair. That's really not how it occurs. It's just that the hair follicle happens to be incredibly sensitive to androgens. So even in women that have normal testosterone with PCOS, they may come to you and say, look, I have this unwanted hair, and their testosterone levels are completely normal. It's just the way that androgen, or floating around testosterone, affects the hair receptors. Next slide, please. Acne and alopecia can also occur, and this is because androgens increase sebum production within the pilosebaceous unit in our skin, and this leads to plugged follicles and acne over time. Androgenic alopecia can also occur. It's not as frequent, thank goodness, but it does present and remains really distressing and causes a lot of mental distress too, because nobody wants to lose hair. It's very distressing. So although it is rare, it occurs. I more frequently see I'd say androgenic balding or androgenic around the temples is where I think most women have, a receding hairline or hair loss, not so much diffuse alopecia, thank goodness. Next slide, please. In the hair follicle, androgen bioactivity is regulated in part by something called 5-alpha reductase. So this takes and converts the circulating testosterone in the system to what's called dihydrotestosterone, which is a much more potent testosterone. And therein is how alopecia or thin hair occurs. Next slide, please. The way that we grade alopecia, it's similar to our Ferryman Galway score. So to standardize it, we can use either the Sinclair scale or the Ludwig scale. You can see the two scales here that most dermatologists or endocrinologists use. Next slide, please. Infertility is also very distressing. In addition to irregular menses, some of the other potential factors that cause infertility are diminished egg competence, endometrial changes that occur and discourage implantation, obesity, and this is associated with subfertility and delayed conception as well. And then also not to be forgotten is male factor infertility or tubal occlusion. That should also be considered. There was a study done in women with PCOS that found a rate of nearly 10% of severe low sperm in their partners and a 5% rate of bilateral tubal occlusion. So about 15% of the time, things outside of PCOS in women who had a documented diagnosis of PCOS. So it's not to be forgotten. And I think generally speaking, it's a lot easier to work up a male for infertility and do a sperm analysis than it is for a woman to undergo, fallopian tube analysis and multiple other tests. So I do refer typically to reproductive endocrinology, and I ask that a patient's partner also be evaluated. Next slide, please. Endometrial cancer is also seen in women with PCOS, and that's because they share many of the same risk factors associated with the development of endometrial cancer. Endometrial cancer has been linked to obesity, elevated insulin levels, diabetes, abnormal uterine bleeding, nulliparous, infertility, and low physical activity. And we'll talk about how we can help protect women's uterine lining in the upcoming slides. Next slide, please. Mental health. So Endocrine Society suggests screening women with PCOS for depression with the PHQ-2. And that's just a questionnaire that can be used in clinic, and referring if a woman, has depression or anxiety. There is a higher lifetime incidence of major depression episodes and recurrent depression, and a higher incidence of suicide attempts in PCOS. More often seen too is eating disorders, anorexia, binge eating, panic disorders are definitely more common in PCOS. And then it appears to be independent of obesity, androgen levels, hirsutism, acne, and infertility. So when all of those things were controlled for, women with PCOS still had, all of the above increases in disease. Next slide, please. Obstructive sleep apnea is something to be aware of and screen for if women are coming in with severe fatigue, complaints of, not sleeping as well, falling asleep during the day, waking up at night with apneic episodes. Women with PCOS were 30 times more likely to have sleep disordered breathing disease and 9 times more likely than controls to have daytime sleepiness. So just be aware of that as well. Next slide, please. So non-alcoholic fatty liver disease and NASH, these are, NASH is a subgroup of non-alcoholic fatty liver disease in which steatosis coexists with liver cell injury and inflammation in the liver. Studies report about 15 to 60% prevalence in the population of PCOS, and there's no approved drug to treat this, although lifestyle therapy, insulin sensitizers, antioxidants can be beneficial. And we'll talk about treatment a little bit more too with the anti-diabetic agents, which can also help with NAFLD and NASH. Next slide, please. Type 2 diabetes. So Endocrine Society recommends the use of an oral glucose tolerance test to screen for impaired glucose tolerance in type 2 diabetes. This is because it's the potential to detect earlier before pregnancy. There's an increased association between cardiovascular disease and impaired glucose tolerance. I feel like most of the time we order an A1C simply because it is much more convenient and easier for the patient to do a one-time A1C as opposed to doing the glucose tolerance test, which takes time, it's uncomfortable, they have to sit in clinic. So we typically do an A1C, although I will say, if a patient is planning a pregnancy, then I typically will offer the oral glucose tolerance test prior to pregnancy, just to make sure that we're detecting it earlier prior to a pregnancy. And then to make sure we're screening for type 2 diabetes at least every 3 to 5 years. In PCOS, there's a 5 to 10-fold increased risk of developing type 2 diabetes in the long run. Next slide, please. There is an increased cardiovascular risk in women with PCOS, and this chart gives us women that are at risk and women that are at high risk. So at risk are things like PCOS coinciding with obesity, cigarette smoking, hypertension, high cholesterol, vascular disease, impaired glucose tolerance, any kind of family history of heart disease. And then women that are at very high risk already have metabolic syndrome or type 2 diabetes. They've already had vascular renal disease or cardiovascular disease, and then sleep apnea. And in those women, I typically refer them to cardiology as well. Next slide, please. The goals of therapy in polycystic ovarian syndrome are to overall reduce the androgens that are floating around, causing all this havoc, to improve reproductive function, decrease their risk for endometrial cancer, ameliorate complications due to insulin resistance, so treating glucose intolerance, hyperlipidemia, hypertension, atherosclerosis, or athogenesis, promoting weight loss, aesthetics, especially, there is an incredible amount of mental distress with hair loss. So making sure that we're helping them with their aesthetics and referring to derm, and I'll talk about some treatments for aesthetics in a minute, and then improving fertility. Next slide, please. So the treatment recommendations are weight loss, so diet, medications, and surgery. Nutrition and dietetics referral are great. At WVU, we have a weight loss center as well. When women have failed, diets, nutrition, exercise programs, and they're still gaining weight, if they're interested in bariatric surgery, I certainly refer them. And then oral contraceptives, including patch, vaginal ring. This is first line therapy after lifestyle changes. So combined oral contraceptives are preferable. You definitely want birth control that has a high estrogen content in it and less of the progestin or androgen content. And then insulin sensitizers that can be used are metformin, and I like the GLP-1 receptor agonists a lot. I didn't put them on here because it's not really within the guideline. But just last week in news, I've been writing GLP-1 receptor agonists like Trulicity and Ozempic for my patients for quite a while now. It's difficult to get them covered. They're very expensive. And so I feel like that's been a real obstacle in care, but sometimes they are covered. And I think it makes a huge difference because those drugs help with insulin sensitivity. They produce insulin from the pancreas. They reduce glucose production, and they help tremendously with weight loss. The biggest obstacle is getting them covered. I don't have a trick for that. We have nurses that do prior authorization and try to help us. But as of right now, I think until the PCOS guidelines really urge GLP-1 receptor agonists first line as opposed to metformin, I think it's going to continue to be hard to get them covered if there isn't a overt diagnosis of type 2 diabetes. Anti-androgen therapy includes spironolactone, and then for fertility, we have things such as clomiphene and letrozole. These are aromatase inhibitors and selective estrogen receptor modulators, and I'll go through each of these therapies in a little bit more depth. Next slide, please. So again, this is just for your reference. I don't expect you to, we're not going to kind of go through this in detail, but I just wanted to give you a little bit more detail for weight loss and the medications, the oral birth control pills, the spironolactone, metformin, etc. Should you want it for reference in your clinic. Next slide, please. The role of weight loss for PCOS, it's beneficial for reproductive health and metabolic dysfunction. It's first-line therapy. Menstrual function is improved in some women with as little as 5 to 10% weight loss. There's also improved insulin resistance and glucose levels. And then we had mentioned bariatric surgery as a treatment for obesity, and this has been shown to reverse a lot of the metabolic and reproductive issues in these patients. So there's been shown to be a high increase in infertility after women do have bariatric surgery, so much so that one of the recommendations immediately following bariatric surgery is to make sure women use contraceptives because there is a spike in fertility after surgery. Next slide, please. Use of metformin in PCOS. So as you can see by the slide, it has a multitude of effects in the liver, decreases gluconeogenesis, has fertility effects, increases ovulation, at the level of the muscle, increases glucose uptake, and then at the level of the fat cells, decreases lipolysis, decreases the amplitude of the LH pulse, which we talked about in the beginning few slides, which was one of the initial, pathophysiology slides that we reviewed. And then in the gut, increases ghrelin, increases gallbladder function, has all good effects on the gut. And as you can see, it also increases the GLP-1 and GIP hormones. Those are the drugs that we just mentioned. So like Trulicity and Ozempic, those are GLP-1 receptor agonist drugs as well. And metformin helps potentiate those gut hormones too. So Endocrine Society recommends metformin in women with PCOS who have type 2 diabetes or impaired glucose tolerance or who fail lifestyle modification. And with lifestyle modification and metformin, there's a decreased progression to type 2 diabetes in up to about 60% of women, which is pretty phenomenal. Next slide, please. Oral birth control pills. So this is one of the most commonly used medicines in PCOS. In addition to the androgen lowering effects, it's likely that they protect the endometrium against hyperplasia and cancer, as they do in the general population, and they reduce the incidence of functional follicular ovarian cysts, also shown in the general population. And then I put avoid norgestrel and levonorgestrel because they have a high amount of androgen content, and they increase the risk of hirsutism. Next slide, please. Spironolactone, this is an androgen blocker. And so it's an oral aldosterone antagonist with anti-androgenic properties. So some of the side effects of this are menstrual irregularities. Unopposed estrogen leads to a buildup of the endometrium and irregular bleeding. Breast tenderness, GI disturbances, headaches, dizziness, and high potassium all need to be monitored. They should be given with oral birth control pills because of the risk of birth defects. They're teratogenic, and also because you don't want the endometrial lining to build up. So again, birth control pills protect the endometrial lining by, in PCOS, I always tell patients, both men and women have estrogen and testosterone. It's just men have a higher amount of testosterone in the system to estrogen. And women typically have higher estrogen to testosterone ratios. And PCOS, unfortunately, because of that abnormal pulse of LH from the pituitary, that causes a higher amount of testosterone to estrogen in women. So birth control pills effectively reverse and change that ratio to now give the female higher estrogen and lower testosterone. Next slide, please. So Vaniqua or a fluorinethrin cream, it's really expensive, not very efficacious, I found, but some women do like to use it for hirsutism. It does slow down hair growth in some women, and it can reduce the visibility. There was a randomized controlled double-blind trial that showed a significant reduction in facial hair growth in active arm within 8 weeks, and at least about 70% of women responding. So I've had kind of mixed reviews on it, but it is something that can be used topically and typically needs to take several months to take an effect just because of the hair growth cycle itself. Next slide, please. The treatment of hirsutism, so some mechanical means are bleaching, plucking, waxing, shaving, depilatory creams, electrolysis, and laser therapy. Laser therapy requires long-term treatment and multiple recurrent treatments, but I found it to be the most successful in women with light skin and dark hair, and it is definitely the most expensive, but the most durable long-term. Next slide, please. Treatment of infertility. I typically do not treat this out of my own clinic. I refer them to a reproductive endocrinologist in the OBGYN clinics, and clomiphene is one of the selective estrogen receptor modulators. And the way that this drug works is it blocks estrogen receptors at the hypothalamus, and it tricks the hypothalamus into releasing GnRH, which in turn releases those sex hormones, the FSH and LH, which we talked about, to stimulate growth of the ovarian follicle. And this in turn stimulates ovulation. So this is certainly something that can be used for fertility. Next slide. So letrozole, it's superior in the live birth rate as compared to clomiphene. This is an aromatase inhibitor. It inhibits estradiol synthesis. And by doing that, it then stimulates the pituitary and the FSH LH to stimulate the follicle, in turn leading to ovulation. Metformin can also be used as adjuvant therapy for infertility, but letrozole is thought to be superior at this point in time. Next slide, please. So these are some of my references, different governing bodies and the different, I talked to you about the NIH and the Androgen Society, the Endocrine Society. So if you want more information, these are some of the guidelines that I used. Does anybody have any questions?
Thank you so much, Dr. Giordano. That was a really informative didactic, and you always do such a wonderful job breaking things down and explaining it. And I don't have any medical background, but you really did a wonderful job, even for someone like me to kind of understand all of that. So thank you. But yeah, any questions, comments, or thoughts from the group, feel free to unmute and just take it away.
Can you go over what you discuss with your patients regarding lifestyle management?
Yeah, thank you so much, Mitra, by the way. My biggest thing, I'll tell you, it's a lot of information to absorb, especially I see a lot of really young females. And what I tell them off the bat is, do not blame yourself. If you're struggling with weight gain and it's really hard to lose weight and you're doing all the right things, you're eating healthy, following good diets, going to the gym, please do not blame yourself for weight gain. It's part of a disease, and it's not something that you've done to bring upon yourself. I refer them to dietitians most of the time because I typically have an hour with not even an hour, 40 minutes is really my allotted time. So I typically try to tell them to avoid carbohydrates. I feel like carbohydrates is what brings on weight gain, but also elevates the A1C. So avoiding carbohydrates, and the best resource for that is the American Diabetes Association website. So I recommend that to all patients, no matter who you are, because it's a sound diet and it uses the Mediterranean diet, which is high in good fats and lean meats like fishes, pork, chicken, nuts, berries. And there are a ton of really great recipes on the American Diabetes Association website that are very low in carbohydrate, higher in protein and fiber as a beginning point. I also make it known to avoid drinking their food. So all of us, these like Starbucks and smoothies and nutritional things that are out there, a lot of those things have a tremendous amount of carbs, sometimes like up to 1,000 or more calories in a drink. So trying to just avoid drinking your food and drinking, water and unsweetened beverages is something that I, try to discuss with people too. But yeah, I think that referring to a dietitian or a nutritionist is important. People that want to do things themselves, I refer to the American Diabetes Association website for recipes. And that's pretty much my starting point. As far as weight loss treatments go, I usually do discuss that. Weight loss medications are frustrating because they're not covered very well from insurance companies. The side effects are sometimes, pretty challenging as well. So I'm sure you all have heard of, phentermine or Qsymia. Phentermine, basically, it speeds up it's like a sympathomimetic. It speeds up your system, makes you feel like you drank a lot of coffee. So the side effects are kind of prohibitive for phentermine, although it's effective. My favorite weight loss drug is the GLP-1 receptor agonists, but coverage is less than ideal. It's really challenging to get those covered in PCOS unless a female has full-blown overt diabetes. And I think that's a great weight loss adjunct, but it's not covered very often. So that's kind of where I start with weight loss or diet and nutrition.
Thank you.
Yeah, just to add to that, I was smaller when I was younger, but I always had really absent periods, like 4 months, 5 months. And when I didn't get diagnosed, I think it is ignored a lot or not noticed, or there's a lot of people suffering from it that don't realize that they are, because there are so many, I think, severities within it too. So I went 1.5 years without a period. And I couldn't afford to go to the doctor at the time in my 20s. So I finally was able to when I had a job that helped me do that. And that's when they discovered it after doing ultrasounds and such. But I find, Kristen, a lot of support groups, like Sisters of PCOS. A lot of women I see on there have luck or better reaction without eating any type of gluten or dairy products, which is really hard. I love beer and I love gluten and I try to get gluten-free pasta, but sometimes I cheat, but it's really hard. And I gained so much weight later on. I'm overweight, I'm obese, I don't have type 2 diabetes, but I take metformin right now and I take spironolactone, but I don't take birth control. So I guess good to know, but they never do any of the exclusion things, the testing that Dr. Giordano was discussing. They never tested me for those other items except for my thyroid. So that's concerning to me. I just feel like there's a lot of not misinformation, but disconnectivity or not connecting the dots between this, syndrome that we have. So it's very difficult. So, those try the gluten dairy thing. Sometimes have hard cheese still, but I gained 30 pounds in a year. And I also started taking an antidepressant. I'm very open book. So I started taking a small amount and that just made it worse. So it's a battle. And I have high cholesterol. So it's I have it all except for the diabetes right now. But it's a challenge. And Dr. G, I try to get on this weight loss drug, but it is expensive and I can't. And it's they want you to get to type 2 diabetes before you can even do it. So, but what about supplements, Dr. G? Do you know about inositol? Have you ever heard of that supplement?
I haven't. Is that from one of your support groups?
So instead of metformin, some women have been taking that, especially if they don't have type 2 diabetes, and my A1C is normal in fasting. I'm still taking metformin, but a lot of individuals on those pages seem to find that helps their period regulation and helps their cravings, because I have some wicked cravings sometimes. That's my dog, sorry.
Yeah, I don't know the data. I don't know the data behind it, honestly. I would have to look that up myself. And we could talk about it, but I don't know it. So I typically just kind of follow being like an academic center and doing academic medicine. I typically follow like evidence-based guidelines. So that means that we have a set of guidelines from governing bodies that have done studies that prove that those medications are safe and effective. That doesn't mean that, you know, maybe a vitamin or a nutrient may not help in the future, or may not help now. There's just not enough data to incorporate inositol into guidelines for us to prescribe it regularly and say that it does help or that it does harm. So for that reason, I stick to guidelines in therapy, and for those reasons, because I know that there's data behind that. With that said, I'm also the type of person that, you know, I usually tell my patients, if there's something that you feel that's really helping you, as long as it's not harming you and it's not causing toxicities and it's not overlapping with your other medicines, I try to be open about, you know, supplements and that type of thing to a certain degree, you know, if it's not causing harm. And I don't know exactly what's in inositol.
Yeah, I don't even.
I would have to research. I'd have to research more, and I would
That's
have
interesting. It's just an
add any-
interesting thought. I think you produce it naturally as well. It's like myoinositol, and they divide it by certain. It's like I think it's like a sugar of some sort. I might be mistaken. Don't quote me. But yeah, that's hard. And then with birth control, I've always been nervous. I don't know if anybody else feels this way about blood clots. And I thought in the past there was some research connecting, you know, that PCOS women might have an increased risk for that, but I didn't know if that was true or not. I don't know how much evidence is there. So I've been on it before, but I've always been nervous to stay on it because of that reason. So I didn't know if there was anybody that had any feedback about that.
Well, I give you a case report. I had a DVT and a PE in 2014 while on birth control. Thankfully, I also had bariatric surgery, so I've lost enough weight that my periods are regular, so I don't have to worry about that aspect of it. I just take metformin. But yes, clots are very scary. I'll contribute that.
that PCOS, the syndrome itself, has a lot of overlapping risk factors to develop blood clots. So, you know, the weight alone, and weight makes it hard to exercise and be active and get out there. And so that is really a risk for clots too. And I think the most frustrating thing about being a doctor in 2021 and 2022 and now is just that, you know, what you guys had mentioned, insurance companies don't give preference and priority to weight loss. So it's basically like, let's allow these terrible things to happen, and then we'll cover a statin, and then we'll cover cardiac surgery, and then we'll cover all of these therapies. But there is no preemptive, okay, let's prevent weight loss. Let's cover bariatric surgery up front when the BMI is 30 to 35. And I think that they're getting a lot better now in doing that. But trying to get weight loss agents and things covered is such an extreme chore because it's considered a preventative in some ways. And that's just really frustrating because you know what your patient needs is just insurance won't let you write it. And that's always a frustrating thing in medicine that we all deal with. And I don't have a solution to that.
Yeah, but just having that understanding is nice. I mean, it is very difficult. And I find myself, I can't be running or biking or going like hardcore. I've been trying to do yoga or walking because I find it benefits me more like mentally as well. For me, if I try to like push myself overly, I feel like it builds up my stress and then I don't see anything happening result wise. Not that I'm having the best results at the moment, but you know what I mean.
I think any amount of activity that you can do and feel comfortable doing that benefits like your mind and body is excellent. Something is better than nothing. You know, even the American Diabetes Association guidelines last year came out with new recommendations because Americans just in general are very sedentary and do a lot of computer work or just sit for hours on end. And so the American Diabetes Association came out with recommendations that said Americans should not be sitting for more than 1 hour at a time, period. So every single hour getting up and moving. And that's not a lot. It doesn't sound like it's a lot, right? You're sitting at a computer and every hour, you know, your phone or something blinks to go off, but it actually makes a big difference to kind of get up and move and not be so sedentary.
Yes, it's
And
hard. It is. It's hard because you get in the zone. You're like, oh my gosh, I can't. One more thing. I got to
Yeah.
do one more thing. And then all of a sudden another hour
Yeah.
goes by. So it's hard.
Yeah, I think prioritizing our health is challenging for all of us. I mean, we all have deadlines. There's so much work. There's so many things that always need done, but the reality of it is, you know, you're the most important thing that needs to be addressed, and your health, your mind and body needs to be addressed, and everything else is noise. It needs to be that way for all of us. And, you know, I say that, but it's also hard for me. You know, I understand I face the same challenges. I am at my computer constantly and, you know, sitting down, seeing patients. And I know it's much easier said than done, but, you know, putting like an alarm on your Apple Watch or something that goes off every hour, that's like, okay, time to get up and time to move for 5 minutes or do some kind of activity, you know, running the stairs at work, walking around the building, something that's active is better than nothing.
And that's actually one of my New Year's resolutions, is to put my physical and mental health first. I think even just taking 5 minutes to do like a guided meditation, or like you said, just running up and down the stairs gets your heart rate up. So I think we can all absolutely incorporate that, put ourselves first. And like you said, that's the most important thing, because you can't be your best self if you take care of yourself. So that's one of my New Year's resolutions. So it's interesting to see that come up in the discussion today. And I do want to thank both Kristen and Elizabeth too for sharing your personal experiences. I know it's not easy to share things that you go through, but I find it so empowering to see women come together and support each other and talk about it. And that's the first step, you know, finding a support group and talking about it, and just finding a good group of people. So that's all of you guys. You guys are all so wonderful. So thank you all so much. We are at the top of the hour, so I'll go ahead and start some of the announcements. But if there are any questions or anything after the fact, as always, you can shoot us an email and we'll make sure to have it addressed. The only announcement that I have is that our next session will be on January 26th, and Dr. Giordano actually will be presenting again on COVID-19 and diabetes. So keep an eye out for that reminder. I hope to see you all there again next time, and have a wonderful rest of your day. And don't forget to put yourself first. All right, take care, everyone. Thanks, Dr. G again.
Thank you.
Bye.
Bye.